And I'm going to start with just a few housekeeping tips. The bathrooms are to the right. I've always wanted to say that on Zoom. Thank you. Hi, I'm Rick Scheffler from the Child and Adolescent Behavioral Health Center of Excellence and the Center for Innovative Practices here at Case Western Reserve University. We're thrilled to have you all today. Join us for our conference. We have done a few of these conferences already, and we're excited really with all of the energy with OhioMHAS, Family First, and the children's initiatives, including the crisis continuum that the governor has really emphasized. Excited to share with you this brand new service that we'll be rolling out through OhioMHAS, Mobile Response Stabilization Service. And we've got a number of experts coming to you today to give their experiences and also their wisdom and expertise. A couple of points. There will be CEUs offered each day. I believe there's 6 today and 4 tomorrow. We'll be entering an evaluation link at the end of each presentation. So make sure that you catch those. We'll put them in the chat. The other piece of information that we wanted to make sure is that we will keep you muted. We do encourage lots of questions. However, each workshop is only 1 hour. So what we're going to do is we're doing something very different. We're going to have actually a question and answer workshop tomorrow at the end of the day, 1:30 to 2:30. We're going to collect all the questions. We'll create basically a very quick FAQ. And we're going to use that time to answer the majority of the questions. If there's time at the end of any of the workshops, I'm sure they'll be happy, the presenters will be happy to honor questions. Okay, all righty. So without further ado, we would like to welcome Lori Chris, the director of the Department of Mental Health and Addiction Services here in Ohio. And Lori is one of is a person that joins us in leadership with lots of experience from the field, and that's not always something that we see at the leadership level. And I think it offers a tremendous amount of credibility to her in the role that she plays. And she's an amazing advocate, not only for providers, but also youth and families for getting the best services that are possible. Lori will offer us with some opening remarks, and then we will jump into our conference day with Dr. Ron Manderscheid. Lori.
Good morning. Thank you so much, Rick, for those kind words. I'm really happy to be here this morning and want to welcome and thank all of you for attending the 2021 MRSS conference. Mobile Response Stabilization Services, MRSS, is important for children, youth, and families in Ohio. And as Governor DeWine has expressed, OhioMHAS program represents an important first line of response in providing timely access to services and in improving outcomes for children and families, and at the same time reducing the stress that law enforcement and emergency departments have experienced in their efforts to best serve these families that are in crisis. And this truth really does drive our goal of expanding MRSS to intercede before urgent behavioral health situations become unmanageable emergencies for families and their caregivers. Our department's vision for Ohio's crisis continuum is for every single Ohioan of every age, including young people, to have access to visible and accessible services and supports that are person-centered, quality-driven, and focused on ensuring people are stabilized and thriving in their own homes and communities. Now, as we've done this work to build out Ohio's crisis system, one of the things that I've heard over the years is that when we are doing system work, we often build a system that's really designed for adults and not designed for youth and families. And so having an evidence-based practice like MRSS and having the voice of youth and families at the table as we design our crisis response system through this department and our collaboration with other departments and with all of our partners in the field is of primary importance, so that we don't just assume that kids are little adults, right? That we're doing this right in a way that's going to have better access, better outcomes, and equity for kids across the state, regardless of where they live. And during this two-day conference, you'll learn from the experiences of the pilot MRSS projects, which are funded through the Engage 2.0 SAMHSA System of Care grant. So in partnership with Governor Mike DeWine's Children Initiative and the Ohio Department of Medicaid, we launched the expansion of MRSS in 18 additional counties this year. In July of 2022, MRSS will be a billable service through Medicaid's Ohio RISE program, and that will further enhance the comprehensive system of care for children and youth. I really appreciate that all of you are here joining us today to build your learning and your relationships as you dive into this work or deepen your practice of MRSS. I hope that you have a great experience and wish you the best for this workshop. Thanks again.
Thanks so much, Director Chris, for your kind comments. We now will introduce Laura Payne, who will introduce our keynote speaker for today.
Good morning, everyone. I can't see the videos. Is Dr. Manderscheid on? We're running a few minutes ahead.
I'm here.
Okay, good morning. Well, then in that case, I will go ahead and introduce our keynote speaker for today. Dr. Ron Manderscheid, PhD, served most recently as the Executive Director at the National Association of County Behavioral Health and Developmental Disability Directors. Concurrently, he is the Executive Director of the National Association for Rural Mental Health, Adjunct Professor at the Department of Mental Health, Bloomberg School of Public Health, Johns Hopkins University, and Adjunct Professor, School of Social Work, University of Southern California. Dr. Manderscheid serves on the boards of the Cosmos Club, the Employee Assistant Research Foundation, the Dania Institute, the Council on Quality and Leadership, the NASMHPD Research Institute, and the National Register of Health Service Psychologists. He also serves as the co-chair of the Coalition for Whole Health. Previously, he served as the Director of Mental Health and Substance Use Programs at the Global Health Sector of SRA International, and in several federal leadership roles at the U.S. Department of Health and Human Services. Throughout his career, he has emphasized and promoted peer and family concerns. He has also authored numerous scientific and professional publications on services to people with mental illness and substance use conditions. Thank you for joining us today, Dr. Manderscheid, and I will turn it over to you.
Okay, thank you very much. And please share the screen so I can bring my PowerPoint up here.
Can you see the screen? I'm about to move right into your PowerPoint.
Okay, are you going to show my PowerPoint?
Yep. Yeah.
Okay, good. Wonderful, wonderful. It's always a point of clarity at the beginning. So thank you all very much for inviting me today. I greatly appreciate having the opportunity to come and speak about crisis services, particularly around children. And I appreciated what Director Chris said about hearing the voice of children and their families. I think that's a very important thing, and sometimes that gets lost in the shuffle of doing the kind of work we do in behavioral health. Okay, let's go ahead here to the next one. I want to go back to what Amanda Gorman said at the inauguration a few months ago. Amanda Gorman said in the final paragraph of her talk, "The new dawn blooms as we free it, for there is always light. If only we're brave enough to see it, if only we're brave enough to be it." So we have to be the light moving the agenda here. She was issuing a very important challenge to all of us. And I know all of you who work in behavioral health care fully understand what she's saying here and fully understand this as part of your mission, going forward here. Okay, please go ahead. I want to also bring greetings from the American Academy of Social Work and Social Welfare. This work you're doing in Ohio on development of mobile crisis teams for children is very important and will be of great interest to the American Academy. And I also bring greetings from the American Public Health Association. American Public Health Association has done a lot of work on the issue of vaccine, on the issue of response to COVID-19, on the issue of response to mitigation factors for COVID-19, and so on. So I bring greetings from both of those organizations. Okay, please go ahead. This is where we're going to go today. I want to start by talking about behavioral health care and its context, how COVID has changed that, how we're moving into population behavioral care, the implications of population behavioral care, and then moving into our communities and crisis response systems. Okay, please go ahead. So first, behavioral health conditions are very pervasive, and I'm sure you all know this, but it deserves repeating here. Please go ahead. "25% of adults and 20% of children and adolescents have diagnosable behavioral health conditions." Those are annual prevalence figures. Those figures have been true for the last 40 years. I remember working on the epidemiologic catchment area project in the early 1980s. We were finding exactly the same prevalence for adults at that time. We didn't have children's data until much later. When we finally did have children's data from at least regional studies, we were getting about 20%. So those numbers literally are very persistent. And we've seen little or no change in those numbers for 30 to 40 years here. And then within those groups, about 6% of adults and 9 to 13% of adolescents have serious and persistent mental health condition. The difference here between adults and children, for adults, to predict that number, it's a flat 6%. So I can use that number pretty much in any state in the United States and I'll have an accurate result. For children, the difference is the rate varies according to the percent of children in a state that are in poverty. So for those states that have higher rates of poverty, the rate of serious and persistent mental health conditions in children is higher in those states. For example, California has one of the highest rates here because California has one of the largest percentages of children in poverty in the United States. Okay, please go ahead. More than 11% of those aged 12 and older use illicit drugs, and more than 2% use prescription drugs for non-medical purposes. This is a very, very serious problem and one that you need to pay particular attention to in your youth population because of the high risk of mortality. We had the highest rate of mortality due to drugs and opioids in the past year that we have ever had. The highest previous number was about 70,000 in 1 year. Last year, we were above 93,000 people. And what's unclear in that number is what percentage of that number is accidental and what percentage of that number actually consists of a suicide that's covered by an overdose. We also have about 50,000 people who die by suicide each year. This is another problem that affects children and adolescents in particular, particularly minority children and adolescents. So I would pay particular attention to that as you move into mobile crisis response teams. About 8.5 million people have co-occurring mental health and substance use conditions. So among people with substance use conditions, two-thirds have a mental health condition. Among people with mental health conditions, 1/3 have substance use conditions. And I'll give you a couple of crosswalks here. If you tell me you have depression, the probability triples you're going to use opioids as an example. Or if you do opioids, I can predict with not about 90% certainty within 30 days of your using opioids, you're also going to develop secondary depression. So there's a high correlation here among these different conditions. Okay, please move ahead. Okay, okay, go ahead. No more than half of adults and 1/4 of children and adolescents with behavioral health conditions receive any care at all. And these were numbers pre-COVID. And it's very predictable, and again, like the epidemiology here, these numbers really haven't changed, even though we've done many, many things in behavioral health over the last 40 years. These are very, very predictable and stable numbers in our epidemiology. Only about 20% of these adults who receive care actually receive care from a behavioral health provider. 80% who receive care are from a primary care provider. It's another important distinction as you think about mobile crisis response teams. How are they going to be linked to the behavioral health system, and how are they going to be linked to the primary care system here? And what is the role of primary care system in Ohio in being a sentinel place for crisis and emergency events for children and adolescents? Many who do not receive care are homeless or incarcerated in city and county jails. And we know the epidemiology there as well. If I were talking to you 20 years ago, I would never mention this was not a problem 20 years ago. This is a problem that's developed as we have not had the capacity in behavioral health to actually provide the care that's needed. And as a result, if you don't receive care and you have a mental illness or substance use condition, the probability goes way up that you're going to become homeless. And once you're homeless, the probability goes way up that you're going to become incarcerated. And that is true both of adults, and it's also true of children and adolescents. Our juvenile justice facilities, have about 70,000 children a day. I would say virtually 100% of those children in those juvenile justice facilities have a behavioral health condition at the time they enter the facility. We've been successful in changing Medicaid coverage. So Medicaid coverage now extends to juvenile justice facilities, so these people can actually receive care while they're in the juvenile justice facility. Okay, please move ahead. And as you all know, and I've been talking about for the last 15 years, the behavioral health field suffers from a severe human resource crisis. And when I described that 15 years ago, when I did a strategic plan on human resources for SAMHSA, I described it as a problem. I would describe it as an out crisis today, because we literally in the last 15 years have done next to nothing about this. So the senior providers, the baby boomers, are leaving in large numbers. Right now, about 10,000 people a day actually go on Social Security in the United States. Give you some indication of the rapid rate that is happening, and that's happening to our providers as well. And that's going to continue every day for the next 10 years. So, and then on the other end, not enough people are entering at the entry level to the field. And the universities have not changed their training at all. They are producing the same numbers of people they've always been producing, and there's not been huge federal incentives to move that agenda. So we moved from having a problem to having a crisis in our behavioral health human resources. Much more reliance is being placed on peer supporters, virtual care, and self-care, and we could spend the whole time today talking about how the field literally overnight in April of 2020 moved from in-person care to virtual care. Peer supporters have become a very big part of our work, and I'm hoping that The concept of peer supporters will be engaged in your mobile crisis response teams, and self-care has become very important. Under the Affordable Care Act, person-centered care has become the underlying philosophy. And if you move person-centered care forward, it moves you in behavioral health to what we would call self-directed care. And there's a lot of work going on in that area currently. Behavioral health care, to be quite honest, has been very slow to adopt integrated care approaches. I think that has accelerated in the virtual world because virtuality has made it much easier to do integrated care. The primary care physician can have a computer sitting right on their desk, and you can bring the behavioral health provider literally into that setting. That's made it much easier and simplified the problem. Previously, it was a large systemic change problem. Now we, I think, through virtuality are reducing this to a much easier clinical change type problem. Okay, move ahead, please. Okay, let's go ahead here. What I'm trying to point out in this, that things really, really have changed since we've gone into COVID here. Okay, go ahead. COVID-19 and its mitigation strategies have generated a behavioral health pandemic, not just a COVID-19 pandemic, but a behavioral health pandemic. CDC survey conducted in June 2020 shows 41, remember the 25% and 20% I told you about before. 41% of adults had at least one mental or behavioral health consequence as a result of COVID-19. 31% anxiety or depression, 26% trauma or stress. Go ahead. 13% increased substance abuse, and 11% contemplated suicide. 11% contemplated suicide. Just think of that. 11% of the population contemplated suicide. And more concerning, then you look at some of these other numbers. I thought these were literally astonishing numbers. 33% of unpaid caregivers contemplated suicide. These are people such as maybe some of you who actually have someone living in your home who's disabled or is elderly and needy or has an intellectual or developmental disability issue. These unpaid caregivers were under tremendous stress during the last 18 months. 25% of those 18 to 24 contemplated suicide, an incredible number. 22% of essential health workers contemplated suicide. So this is a huge, huge issue for us and a huge impact primarily of the mitigation factors due to COVID-19, such as social isolation, loneliness, being at home, being forced to be at home for long periods of time, not being able to interact socially with people. They have taken a tremendous toll. And I think there's huge recognition of this now at the national level. I think the Congress recognizes this. I think the White House recognizes this. I think there is an opportunity for behavioral health right now that hasn't existed for a very, very long time, because they all themselves have had experience of some of these very things. More recent data from CDC suggests that these rates have climbed to 50+% since January of 2021. So if I contrast the 25% with the 50+%, the numbers have doubled. Our behavioral health problems have doubled in the COVID period here. Okay, please go ahead. Thus, we're in a behavioral health pandemic. Please go ahead. Okay, behavioral health care also has changed. Let's go ahead. And I mentioned this just a minute ago. In 1 month, April 2020, behavioral health transitioned from interpersonal to virtual. And this has led to very important learnings. One of the things we learned, for example, in this, that some people do much better with virtual care than they do with interpersonal care. And if you think about that, in the virtual world here, in this presentation, we're all equal. We all have one little box here, and we all have the same level of control. In care that's interpersonal, the consumer goes to the provider's office. Who's in control? The provider's in control of that interaction. So there's a much more egalitarian relationship in virtual care than there is in interpersonal care. And I think for some people who need that, that has helped that care be more effective, one group. Another group has done much worse in virtual care versus interpersonal care because they need the interpersonal connection. They need the daily chat group. They need all of these things. And when they're prevented from doing that, then they begin to cycle down. And that has happened to a large number of people in the last 18 months. And there have been various tools used with that, giving iPads, for example, to consumers. So consumers could chat with their providers at a more willing basis. They could conduct chat groups during the day with peers and colleagues and so on. We're experimenting with all of that. But again, and I teach virtually at USC, and I would have 15 or 20 students in each of these courses, and the whole course is virtual. I would say virtual teaching is about 80% as good as in-person teaching. You don't get all the same verbal and nonverbal cues from people virtually that you do in person. And in teaching, those cues are very important, and in behavioral health care, they're very important. So I would say behavioral health care done virtually is probably about 80% and 85% as good as done in person. Another issue we had in this period, behavioral health care providers had great difficulty acquiring personal protective equipment because they weren't considered to be essential health providers. So if that's true in Ohio, or if that's true in your county, you need to change that, because there will be other crises here where you're going to need to be considered an essential health provider. And if you aren't considered an essential health provider, you'll simply be passed over for this equipment. So any of our providers who initially in April of 2020 who worked in inpatient or residential facilities couldn't get the personal protective equipment, were putting themselves and their family and their children at risk by going into those facilities that had a very large rate of COVID at that time. So very simple concept here, but very, very important. And then we also had the reverse phenomenon. The mental hospitals and local jails deinstitutionalized very rapidly last spring. So they said, we're going to close the front door, open the back door, we're going to let people go. And they never made any arrangement with the community that this was going to happen. So that led to problems in local communities of having a much larger number of people out there who weren't linked to the local behavioral health system. They weren't linked to care coordinators, et cetera. And a lot of those people then began, rapidly cycling in and out of jails and so on. So we've learned in COVID things we should and shouldn't be doing here as we move forward. Okay, please go ahead. So originally, back in April, when behavioral health organizations went to virtuality, their income fell by 40 to 50%. And I would say now that has mainly recovered. They're back probably up at 90 to 95% of where they were, because they've adapted to virtuality. We've gotten higher rates of reimbursement for virtual care. We've gone through all those cycles of advocacy with CMS on Medicaid, Medicare, et cetera. Medicare ultimately was extended to telephonic care, not just visual care, virtually, and so on. So all of those things have made a huge difference, and I think our providers have mainly recovered. What hasn't fully happened yet is reopening of our provider facilities to interpersonal care. And I would say that is still problematical. I would say if you were asking for advice, watch what happens in your local community to your local schools, and how moving from virtuality to interpersonal education actually works this fall will give you a good indication of how you should or should not be opening your interpersonal practice, basically. Important gains made in expanding virtual behavioral care may be limited unless permanent extensions can be achieved through federal Medicaid and Medicare, and we are still working that issue. I think there's huge support on the Hill. CMS probably cannot do this without legislation, but there's huge support on the Hill to actually do this, because people have recognized the tremendous role that virtuality has played in both Medicaid and Medicare in the last 18 months. And then an important thing also happened. The estimated financial shortfall in behavioral care is about $38 billion. And this has occurred partly due to pre-COVID things, but also due to COVID. So in states, it was 500 billion, in counties, 150 billion. We got about half of this was included in the American Rescue Plan. So 300 billion went to states and 69 billion went to counties. So you need to ask in Ohio, how much of your part of the 300 billion is going into behavioral health care, or how much of the 69 billion that went to counties is going into behavioral health care in Ohio, basically. So we didn't get the full 500 or the full 150 billion, but we got a very good down payment on it. And that should be partly a down payment on this $38 billion shortfall that we have in behavioral health care as well. Okay, please go ahead. Okay, let's go ahead. So what can be done about the crisis that I've painted here for you? So the current crisis in behavioral health care can be partially mitigated through implementing population behavioral health care. So I want to devote part of this talk about talking about population behavioral care, because prevention is always to be preferred over treatment. If I can prevent a crisis from ever occurring, that will be better for the person. That will cost less money. That will be better overall. Such changes also will mitigate personal behavioral health crises in the community. Okay, go ahead. So I want to give you the underlying model here. So I think, again, although coming only slowly, population behavioral care is now seen as critical to the future behavioral health care field, including for crisis care. The basic underlying model of population behavioral health care you see here. So you look at a community saying, what are the negative social and physical determinants of health in that community? Who is affected by which negative social and physical determinants of health? What are the effects of that? So one of the effects of that we know in spades in behavior is personal and family trauma occur as a result of these problems. That leads to health and behavioral health consequences, and that leads to the need for care and support. So what I'm arguing is we want to cut into that problem at the very first level. We want to cut into that problem at the negative social and physical determinants of health level, at least initially. If we can do that, if we can change those negative social and physical determinants of health, we can then affect the level of personal and family trauma for adults and for children. We can affect how that rolls down to become health and behavioral health conditions, and we can roll down to reducing the need for care and support. So I'm making a huge plea here that when you do your work on your mobile crisis team, don't forget the importance of that team doing work in the community on the negative social and physical determinants of health. Now, obviously, not everybody is going to be affected by every negative social and physical determinant of health. The trick here is understanding who is affected by which determinants. So which subgroups are affected so that you can direct then population interventions at those subgroups. For example, one of the things we know about people with behavioral health conditions is that there are certain triggers for trauma, and there are certain triggers for crises. One of the triggers for trauma and crises is a crisis in the family unit of some type. And this is true for adults and for children. So if I know that I have a child or I have an adult that comes from a family that's prone to crises, I think I should pay attention to that and ask, what can I do to change the nature of the crisis in that family so that doesn't roll down to become trauma, become a behavioral health consequence, and need for crisis intervention. Very, very important. And I could talk here about ACEs as well. We've had a lot of learning about ACEs with children, adverse childhood events in children. Those adverse childhood events come from negative social and physical determinants of health for those children. And if children are exposed to 6 or more ACEs in a certain period of time, I will predict with 96% certainty by the time they are 18 years old, they will have a behavioral health condition. It's almost 100% predictable. And it flows right into this very model. So the argument here is when you work on your mobile crisis teams, think also about things that can be done in the community. And I'm going to come back and talk more about the community in a few minutes here. Okay, please go ahead. And all of you know many of these things. We've learned over the last 15 or 20 years that trauma causes about 85% of all behavioral health conditions. I mentioned adverse childhood experiences a minute ago. And our response to that has been to introduce trauma-informed care and trauma-informed recovery, which are very important. I'm arguing here we also want to introduce work on the social and physical determinants of health. We want to move upstream. Now recognize that persons in the behavioral health care field also will need training in public health and community interventions. Joint degrees are becoming more common. So when I teach people in the social work field, I get many people coming to me now asking me, how can I get a joint MSW and MPH? Where can I get a joint MSW and MPH? And I always give them kudos because I say, these are the people for the future. These are the people who are going to inherit the earth here because they're going to be able to walk back and forth between these different levels, a level of clinical intervention and a level of macro intervention with people. I'm running to be the president of the American Public Health Association right now. One of the arguments in my platform is that every member of APHA, no matter what their discipline, whether they're a primary care physician or a behavioral health specialist, or they're a dentist, or they're a nurse, need to have some basic training, a course or two in public health, not because they're going to become the expert, but because then they know enough of how to work with people in the public health field. So I will ask you for your mobile crisis teams, how are you working with your county public health departments in Ohio to implement these crisis response teams? And we can talk further about that as we go forward. Okay, please go ahead. So the questions: can we use population behavioral care strategies to prevent and reduce the behavioral health and social effects of COVID-19 and its mitigation efforts? And I would argue, yes, we can. And can we use population behavioral care strategies to prevent and reduce personal behavioral health crises that occur in the community? And I would argue, yes, we can. Okay, please go ahead. Go ahead. So, talk a little bit further about population behavioral care. And population behavioral care, the essence of disease prevention and health promotion is changing community level negative social and physical determinants of health and implementing positive ones. To do this, we will need to deconstruct these determinants, identify their origins, and modify these origins. And family crisis is a good example of that. Thus, we can bring change to communities that will result in population level change for all who are exposed to the determinants. And the underlying idea here again is in every community, you'll have a subset of people exposed to a particular set of determinants that another group is not exposed to. You have to identify those groups and then intervene with population interventions in those groups that are exposed to those particular determinants. Okay, please go ahead. Negative social and physical determinants range from simple to complex, from rats in a house to poor quality education or poverty. So rats in a house, not very nice, but it isn't a complex thing. You can eliminate the rats in the house fairly easily. Eliminating poverty is a much more complex thing, obviously, because it's a much more complex phenomenon. Positive social and physical determinants also range from simple to complex, from good quality housing to support a supportive environment that promotes resilience. These are all concepts that can be applied to the social and physical determinants of health. We will need to develop the capacity to address the full range of these determinants. Okay, please go ahead. This is a critical sentence in the whole talk. To do this, public health strategies directed at changing community social and physical determinants will need to be linked to population health management strategies directed at subsets of people who have similar exposure to these determinants. A key part of this work will involve extensive collaboration that spans public health, behavioral health, population health management, and healthcare. And I'll go through a little of example here in a minute. Just go ahead, please. Okay, go ahead. It says, you got a rare condition called good health. Frankly, we're not sure how to treat it. Go ahead. So we had a very important insight in 1981, and that important insight is that health and disease are not two ends of the same continuum. Health and disease are two continua, which I show here as no disease to severe disease, one continuum, and very good well-being to very poor well-being as the other continuum. Okay, go ahead. As soon as I set up those two continua, you see I can have four subpopulations, which I call population 1, 2, 3, and 4 here. And it should be very obvious to you that someone who's in population 1, very good well-being, no disease, is very different than someone who is in population 4, severe disease with very poor well-being. Just that simple division becomes, so you think about how would you take this particular model and apply it to children who are developing behavioral health conditions or adults who are developing behavioral health conditions. And it should also be obvious to you that when I do this subdivision, the interventions I'm going to use are going to vary very dramatically. So those who are in population 1 want to stay that way. So they're going to want preventive interventions that help them stay healthy with a very good sense of well-being. The trick for population 4 is how do I move people in population 4 maybe up to population 2 and then maybe over to population 1. Okay, let's move to the next overhead here. So I diagrammed this problem for behavioral health. So same idea, a little bit different graphic, but same underlying idea. So I start in the lower right-hand quadrant, which is my population 4, excuse me, people with high morbidity and mortality, little self-help or hope. It's a classic group of severe people in behavioral health. And I don't care whether it's children or adults, it's true for both. If I move horizontally in this, and my horizontal dimension here is disease versus no disease, I'm into traditional biopsychosocial interventions. And I'm arguing here that by itself will not move you up into population 1. So simply doing traditional biopsychosocial interventions will not move you into population 1. You have to get engaged, go up to the upper right-hand quadrant. You have to get into things like self-help, social support, changes in unhealthy lifestyle. You have to change the nature of the context here for the person and get the person engaged. Very different process. And only if you do both of those things will you be able to move to what I called population 1 in the previous one, recovery and health in the upper left-hand corner here. So you can take this model and apply it directly to behavioral health and people with behavioral health conditions. Okay, move ahead. Now, what I want to add to this idea, again, I've got the illness dimension is my horizontal dimension, my well-being dimension is my vertical dimension. There is a third dimension to this. You have to consider the community. And that's where the social and physical determinants of health come in. Okay, go ahead. Population health management can partition populations into different levels of exposure to specific social and physical determinants of health and into different levels of propensity to experience crises. That's a critical sentence again. Population health management can partition populations into different levels of exposure to specific social and physical determinants of health and into different levels of propensity to experience crises. Thus, population behavioral care can modify these determinants, their antecedents, and their consequences. Okay, go ahead. A similar approach can be used to address systemic racism. And go ahead. I think I have one or two slides. And this will be true with children as well here, because systemic racism extends to children, not only adults, basically. Systemic racism is baked into our basic community institutions, education, economy, religion, family, healthcare. You can take any of them, education. Why do certain people do very well in the educational system and others do very poorly? For example, I can go to Baltimore and I can predict that next spring, about 30% of the graduating class for the city of Baltimore will not graduate. They will never finish high school. Who are those people? They are predominantly Blacks, basically. Why is that? That is because the education system in Baltimore is not tilted toward that population, basically. As a result, minority persons experience trauma through these institutions via negative social and physical determinants of health. Thus, in the extreme, these minority persons will develop adverse health and behavioral health consequences as a result of exposure to these determinants, in some cases, even death. Blacks exposed to severe systemic racism can die up to 11 years younger than other people simply as a result of the systemic racism. Okay, go ahead. What are the sources of the systemic racism determinants? Power dynamics in our institutions, status power, economic power, political power, personal power, knowledge power, all types of power. The solution will involve organizing, engaging, and changing these power dynamics. For example, in the community schools, how you're going to change the power dynamics in the community schools so 30% of every graduating class in our urban schools is not lost. Becomes a fundamental issue, basically. Go ahead. Key partnerships will need to be built among businesses, not-for-profit entities, and government agencies to change the power dynamics in our institutions that support systemic racism and its effects. Once the power dynamics have been changed, then public health, population behavioral care, population health management, and healthcare can modify the relevant social and physical determinants of health that result from systemic racism. So it's the same underlying model that I showed you before can be applied to systemic racism as well. And so we know that systemic racism affects youth and adolescents. Okay, please go ahead. I want to go off on a little tangent here. Building communities is an important tool to prevent and reduce personal behavioral health crises. So go ahead. So I'm involved in an international rural behavioral health collaborative where I am in pretty much monthly meetings with people from the UK, Australia, New Zealand, Ireland, Scandinavian countries, talking about how communities are self-organizing. So we've had presentations from the Hog Foundation about 5 counties in Texas. We've had presentations from the Canadians about some counties and provinces in Canada that are working with indigenous populations. And we most recently had presentations from Australia, on the south side of Australia, about communities. And all of these presentations end up, if you listen to all of them, centering on a number of things, understanding how communities can be organized and self-organized to address community problems, including behavioral health crises. So I was just struck with, listening to these various presentations from these communities. And the presentation is not by a university academic who comes in with a briefcase to tell them what to do. These presentations are by people from the communities themselves. I mentioned the 5 counties in Texas, the Hog Foundations. I also mentioned Canada and Australia, and we're going to be hearing from New Zealand next month. And we're planning additional outreach too. There should be another presentation on communities in the Netherlands. So the point being, in all these different places, started independently by all these different people, it's pretty much centering on the same approaches. And our goal in doing this in the Rural Behavioral Health Collaborative is to learn what the best practices are so they can be transported out into other communities. Okay, go ahead. So what are some of the things we've learned? I call first thing foundational. Always listen to your community. So when you're setting up your crisis response teams, listen to the community. Bring the people in. What does the community have to say about what you're doing and what the problem is? Elicit their support. Elicit their input. Secondly, redefine inclusivity. Bring in historically excluded groups. And I don't even have to come to your communities. I would dare say in every one of your communities, you can identify people who've been historically excluded. In some communities, those are going to be minority people, they're going to be Blacks, they're going to be Hispanics, they're going to be American Indians. In other communities, it's going to be elderly people, and on and on and on. Redefine inclusivity so everybody can be at the table in a more equalitarian type way. And third, get things done through relationships and interactions. And there was a very important concept that came up in the Hog presentation, that we shouldn't be building collaboratives, we should be building networks. And if you think about that, a collaborative is a coming together of pre-existing entities that have pre-existing ideas about how things should be organized. A network is a more nascent type event where I create a relationship with one person, then we create a relationship with a third, and so on. So networks are more amenable to change than our collaboratives. Hence, get things done through relationships and interactions. And what if you do these things, what these communities then experienced is new people come to the table, new leaders start emerging, local leaders start emerging in these communities. People become more willing to talk about the problems. For example, in one of the Hog communities, the problem was homelessness. And eventually, the homeless people in that community actually helped design solutions to the homeless problem in that community. It was amazing. But you have to be listening to these people in order for these things to actually happen. So what we're trying to do is move from an approach based upon traditional coalitions to one based upon networks here, where you're doing network building. Once networks are developed, shared leadership can begin to emerge. This was described by the Hog people as leaderful groups. Every group has potential leaders in it if you can tap into them. And they are representatives of the community. And if you can work with them, you can work with the community, basically. Okay, move ahead. Okay, now I want to take some of these ideas and talk about building personal crisis response systems, which is the reason you really invited me to talk here today. Okay, let's go ahead here. Building personal crisis response systems. So say a few statements of context here. So our discussion of personal crisis response systems has come from kind of a murmur, I would say 5 or 6 years ago, to a thunderous roar at the present time. And we've been able to do that because we've kept talking and talking and talking about incarceration of people with behavioral health conditions, whether they be adults or whether they be children. We've been talking about these people not getting any care. We've been talking about these people cycling in and out of jails and so on. And then if we want to shut down the cycling in and out of jails, one of the first things that occurs is you have to have a way to divert people. How are you going to divert people from the jail? Then you start thinking, well, what do I need? I need a diversion center. How am I going to get people to the diversion center? I need mobile crisis response teams. You need to have capacity in your community for what I call virtual inreach and outreach. So I need to be able to call a warm line in the community if I'm having a problem. And I probably need to be able to call that warm line, whether I'm an adult or a child. We need to think about all these things. And outreach, we need to be able to outreach people who we think are going into crises. It isn't all one-way communication. So there are multiple tiers here that are involved in creating a crisis response system. And it's moved from being a murmur to being thunderous. When that happens, excuse me, when that happens, then the feds get involved. So the feds have gotten involved in this through the block grants. So right now, a portion of the block grants are dedicated to building crisis response systems, as they should be. So there will be some resources available to do some of these things. And so you want to look at, what's happening to the block grants that are coming into Ohio on both the mental health side and the substance use side. What are the plans for developing crisis response systems in both of these fields? How are the two fields working together? How are children being brought into this picture? All these things need to be part of your agenda going forward. And now is the time to do that, basically. Now is the time to do that, because this is on the docket nationally, that's on the docket of the states. What are some related activities? Crisis intervention training for police. And I would ask you, how many of the police in Ohio have had at least some level of fundamental crisis intervention training, or after several years retraining? Is this an automatic part of policing in Ohio or not? Mental health first aid for key groups in the community. So have your teachers in Ohio had mental health first aid training? And then the third level here, and we probably don't have much time to talk about it, but it must be on your agenda, successfully implementing the new 988 system. Now, 988 will go up on, I think it's July 12th of 2022. It is not simply a technological problem of putting up the 988 system in lieu of 911. And even it isn't simply the problem of staffing the 988 number, it is getting the local connections to intervene with people locally on the ground once they've gone through the 988 number. So I call the 988 number, someone answers, I talk to that person, and they say, well, you need to be referred to Community X. They refer me down, several things could happen. There is no place to refer me. 2, there's a telephone number I'm referred down to, and there's no answer to the telephone number. Or 3rd, there's a telephone number and someone answers and that person picks up that case locally. If there is no local pickup of this, the 988 system will not work. And so the biggest issue we have here is, I don't think, is the technological issue. The telephone company will be very good about making 988 work, and they'll be very good about hiding a little fee in everybody's telephone bill to pay for it and so on. What will be much more difficult will be building the local infrastructure we need to have in order to do this on the ground in every community. I was involved in a National Academy of Science meeting on this just a couple of weeks ago. And it was very clear to me that although a lot is being done at the national level, we need to accelerate that work, and we need to put much more effort into this if it's going to actually be turned around by July 12th of 2022. Okay, go ahead. Some examples of some of the things that you could look at to see how things are actually working. So in Kansas, it was not possible to develop crisis diversion centers in every single county because they have a lot of rural counties. Ohio has a lot of rural counties. You ask the question, how are we going to do this? Well, in Kansas, we actually held, and the we here is my organization, NACBID, held meetings in Kansas. We had the Kansas governor there. We had the senior people from the Kansas legislature there. We had the behavioral health people. We spent a whole day and we agreed we would create regional crisis diversion centers in Kansas. And the state legislature people, Republicans, agreed to do this. That has gone ahead, and that is literally being implemented as I'm talking here. And that is the solution for counties that don't have the wherewithal to actually do this on their own. And most rural counties will not have the wherewithal to do this. Another good example of this, created by a county crisis diversion center set up in Washington County, Oregon. Washington County, Oregon is a suburb of Portland. The county executive and the county board said, oh my God, we have a huge problem of people going to jail here in Washington County. We have to intervene in this. They lucked out. Yahoo had 2 buildings right next to a metro center that they gave to the county for the crisis diversion center. Washington County set up the staffing for that center. Initially, when they set up the staffing, 100% of the cost was paid by Washington County. Within 18 months of operating this center, I think they said 58% of their revenue was coming from Medicaid. And if I went back and asked them now, I expect it to be a much higher percentage. In LA County, big place, LA County project to move crisis response from the police department to EMS responders. So I ask you, why do the police have to be the ones to respond to behavioral health crises when we have other systems that were designed for crises and EMS responders? How would you link mobile crisis response teams that you're thinking of in Ohio to the EMS system? Question for you, basically. And then crisis intervention training for police. There are very good programs in San Antonio, Texas, and Memphis, Tennessee, for police to actually do these things. So there are examples of many of these things that are already being done here. Okay, please go ahead. A key feature of these crisis response systems, and I want to emphasize, I mentioned this before and emphasize it again, peer workers should be engaged at all levels of local crisis response systems, from warm and hot lines to mobile teams to diversion centers. Peers can play a huge role in bringing people into diversion centers. They can play a huge role in diffusing crises through mobile teams, and they can play a huge role in working with people before a crisis ever becomes full-blown through warm and hot lines, basically. So don't forget peers in the work you're doing here, and ask the question how peers could be involved. And I make a plea again, as you think about this and set these things up, also engage children and adolescents in your conversation and their family members about how this should be done. Engage local indigenous community leaders in this so they know what you're trying to do and so they support what you're trying to do. There's a lot of interpersonal work that's needed here to actually make these systems work well when they're set up. I want to also point out that consumer-operated crisis respite services should be available. One of my students from Hopkins actually is a person who developed and tested these, and there's a very good paper on consumer-operated crisis respite services that you may want to look at. Persons at particular risk of a crisis should have a peer buddy who checks in at frequent intervals. And this would be true of one of my students at USC developed a peer buddy system for schools, for people who were having difficulty in schools, people with developing young people in middle school or beginning to develop behavioral health problems who needed to have a peer buddy who would work with them, help them, get social emotional training to them, all those things. So think of a peer buddy system as well here, basically. Okay, go ahead. So I know I've given you an awful lot of material, but I want to assure you that you can put it all together, basically. You can put it all together. Okay, go ahead. So if we try to put together everything I tried to tell you here in the last 40 minutes or so, community level prevention through addressing the social and physical determinants of health can prevent a lot of downstream crises. So as you're developing your work and setting up your mobile teams, think how the mobile teams can be involved in this level of activity. You also need community level population behavioral care to reduce behavioral health crises. So most behavioral health care systems are moving to some type of population level approaches. You need to see how that is developing in Ohio and how that can be linked to your effort to reduce community behavioral health crises. Appropriate training of police and key community groups. So, have your police been trained? Have your teachers been trained? Have your community leaders, have your county executives and your county board people been trained in these things? And finally, configuring a 3-tiered community crisis response system that has the various elements. It has the Gorman hotlines, it has the mobile crisis response teams, and it has the diversion center or some variant of the diversion center. And let me say one more statement about the diversion center does not need to be a Cadillac model. It does not need to be a brand new building that somebody builds somewhere. It may be something as simple as one room in the county office building that's used part-time, or it may be as simple as a trailer pulled onto the grounds of the county detention facility where people are checked for behavioral health conditions before they are admitted to jail. It can be something very simple. And, think about all of those things and put them together. So let's go ahead here. So that's my final overhead. I do commentaries on many of these things. I publish them in Behavioral Healthcare Executive. I invite you to read some of my commentaries. You can access them at www.behavioral.net and go to the next overhead because I think it will show my contact. Here's my contact information. You want to get a hold of me, talk with me about anything that I've talked about here. I'm happy to do that. And I think I'm done. And I think we can open up for a couple of minutes of questions here.
Thank you so much, Dr. Manderscheid. Yeah, we have a few minutes. Are there any questions in the chat, Rick or Matt? I'm not able to see them.
Let me look in the chat box.
There aren't any currently, no.
So if anyone has any questions, you can feel free to type those in the chat box. While we're waiting, we will also be posting the link for the survey for this keynote session that you need to fill out if you would like to earn continuing education credit. And then we will be looking at the Zoom report to make sure that you need to attend the full hour to earn that credit. So please only request CE credit if you attended the full session. Thank you. Then I'll just give it a few minutes in case anyone has any questions. That was a lot of information. Thank you.
One other housekeeping piece is that I took the liberty of sending the PowerPoint slides for the full day, today and tomorrow, to everyone, to their email addresses. So a couple of them got sent back because the file's fairly large. So if you didn't get them, just put it in the chat and I'll be happy to figure out a way to get those to you. Wilma Townsend asks, could you say a little bit more? Just left.
Yeah.
Could you say a little bit more about the makeup of a conversion center?
So a diversion center, I would say. So the underlying idea of diversion center is a place where short-term care or fulfilling of other needs can be provided to get a person linked back in with longer-term behavioral health care if they have a behavioral health condition. So that's its purpose, to prevent the person from going to jail, to meet their immediate needs when they come into the diversion center, and then to link them back to a more formal part of the behavioral health system in the community, basically. And in thinking about that, you know, each of those parts is very important. So when someone comes in, you know, and let's say the person is brought in by the police, someone comes in, they may have any number of needs. They may have a need, if they're homeless, they may have a need to actually sleep for a period of time. They may have a need to have a shower. They may have a need to have food. They may have a need to be on meds because they're off their meds. It's just not totally predictable. They may have a need to talk to somebody that they're out of communication with, that because their cell phone is, it could be almost any of those things. So these centers need to be pretty broad ranging to meet that broad range of activities. I visited several of these centers in LA, and they have the capacity to do all of the things that I just mentioned, in addition to doing, you know, more formal behavioral health care. I think initially, the first hour or two that a person comes in, they're going to have these more fundamental needs, basically. And then after the person has slept or they've taken their shower or whatever, then you may be able to move on and do some more formal behavioral health things. And then, you know, the center is also going to need to be able to find out, you know, where this person lives. Are they homeless? You know, has this person had connection with the county behavioral health system or the community behavioral health system? Does this person actually have a care coordinator or a case manager? All those things are going to be important in getting the person linked back to the more formal community. The diversion center is not intended as a permanent place for care. It's intended as a transition place and transitioning the person from being at risk of being in jail or a juvenile justice facility to actually moving back into the community under more formal care with a care coordinator in the community. And so these various centers that I was telling you about, the one in Washington County, Oregon, has that range of activities. The centers I visited in LA have that range of activities and so on. And so in thinking of this, you need to think of this not as you would think of a community mental health center. You need to think of this more as an outreach center in the community that does a range of functions for people in that community, basically. So hopefully, Wilma, that answers your question.
It does.
Okay. Okay. Joyce Collins has a question here. But I want to be also respectful of your time. So when my time is up, cut me off here.
I think we're right up against it here in terms of the 10 o'clock hour. So I think what we'll do is we'll save the questions. We'll put them and maybe Dr. Manderscheid, what we could do is have you take a look at them. If you have any, have any time to do some quick answers, that would be fantastic. And then we'll share them during our question and answer period tomorrow.
Okay.
We have a bit more time.
Okay, very good.
Thank
Thank you again for inviting me. You're doing God's work. Keep on doing it. It's all good.
Thanks, Ron.
Thank you again.